Bismillahirrahmanirrahim. The topic of our discussion today is that of the ectopic pregnancy. This is basically the NICE guideline. Okay, so we will study the salient features in this guideline. Content, just leave that. Okay, in overview, what is it is written that this guideline covers diagnosis and managing ectopic pregnancy and miscarriage in women with the complications such as bleeding, pain in early pregnancy, that is up to 13 completed weeks of pregnancy. Now, who is it for? This guideline is basically for healthcare professionals, for commissioners, and women with the complications in early pregnancy up to 13 completed weeks of pregnancy. Okay, so now leave these things, these are not very important. So we will go for early pregnancy assessments. There are specific centers for that. Early pregnancy assessment should be a dedicated service provided by the healthcare professional competent to diagnose and care for the woman with the pain or bleeding in early pregnancy and offer ultrasound and assessment of the fetal HCG, and by a staff healthcare professionals be staffed by the healthcare professional with training in the sensitive communication and breaking bad news. And early pregnancy assessment services should accept the self-referral from the women who have had recurrent miscarriages or previous ectopic or molar pregnancy. And although additional care for the women with recurrent miscarriages is not included in the scope of this guideline, the guideline development group recognized that it is common clinical practice to allow these women to self-refer to any early pregnancy assessment service and wish that this is remain the case. Okay, now coming to the main points, that what are the symptoms and signs of ectopic pregnancy and initial assessment. First of all, refer the women who are hemodynamically unstable or in whom there is significant concern about the degree of the pain or bleeding directly to an accident and emergency department. Be aware that the typical presentation of ectopic pregnancy is common, and be aware that ectopic pregnancy can presents with a variety of the symptoms. Even if the symptoms are less common, it may be significant. Now, symptoms of ectopic pregnancy include the common symptoms like abdominal or the pelvic pain, amenorrhea or the missed period, vaginal bleeding with or without clots. Other reported symptoms include the breast tenderness, gastrointestinal symptoms, dizziness, fainting or syncope, and shoulder pain, urinary symptoms, passage of the tissue, and rectal pain or the pain on defecations. Now, be aware that ectopic pregnancy can present with a variety of signs on examination by healthcare professionals, and signs of ectopic pregnancy include some more common signs like pelvic tenderness, adnexal masses, abdominal tenderness, and other reported signs include signs of cervical motion tenderness, bone tenderness, or peritoneal signs, pallor, abdominal tenderness, enlarged uterus, tachycardia, which is more than 100 beats per minute pulse, or hypertension of less than 100 per 60 millimeter mercury, the blood pressure, shock or collapse, and orthostatic hypotension. Now, during clinical assessment of the women of the reproductive age, be aware that they may be pregnant and think about offering pregnancy tests even when the symptoms are not specific, and the symptoms and the signs of ectopic pregnancy are can resembles the common symptoms and sign of other condition, for example gastrointestinal condition or UTI. All the healthcare professionals involved in the care of women of reproductive age should have access to the pregnancy test and refer immediately to the early pregnancy service or out of the hours gynecology service if early pregnancy services is not available, for further assessment of the woman with a positive pregnancy test and the following on examination: pain, abdominal tenderness, pelvic tenderness, cervical motion tenderness. Exclude the possibility of the ectopic pregnancy even in the absence of the risk factors such as the previous ectopic pregnancy, because about a third of the women with ectopic pregnancy will have no non-risk factors. So that is important point. How much patients will have not known risk factor? That is 1/3. Refer to early pregnancy assessment service or out of the reach gynecology gynecology service if the early pregnancy assessment service is not available with the bleeding or other symptoms and sign of the early pregnancy complication. who have been in a pregnancy over 6 weeks of gestation or more, or pregnancy with uncertain gestation, and the urgency of this referral depends upon the clinical situation and use expected management for the woman with a pregnancy of less than 6 weeks. Gestations who are bleeding but not in pain, or who have no risk factors such as previous ectopic pregnancy, advise these women to return if the bleeding continues or the pain develops, and to repeat a urine pregnancy test after 7 to 10 days and return if it is positive. A negative pregnancy test means that pregnancy has miscarried. Now, refer the woman who returned with a worsening of the symptoms and signs that could suggest an ectopic pregnancy to an early pregnancy assessment service, or out of the reach of the gynecology service if the early pregnancy assessment service is not available for the further assessment. The decision about whether she should be seen immediately or within 24 hours will depend upon the clinical situation. If the woman is referred to the early pregnancy assessment service or out of the reach of the gynecology service if early pregnancy assessment service is not available, explain the reason for the referral and what she can expect when she arrives. Now, diagnosis of viable intratranquil pregnancy and triple ectopic pregnancy offered the women who attend an early pregnancy assessment service or out of the reach of the gynecology service. If an early pregnancy assessment service is not available, a transvaginal ultrasound scans to identify the location of pregnancy and whether there is a fetal pole and the heartbeat. Consider an abdominal ultrasound scan for the woman with the enlarged uterus or other pelvic pathology such as fibroid or ovarian cyst. If transvaginal scan is unacceptable to the woman, offer transabdominal ultrasound and explain the limitation of this method of the scanning. Now, using ultrasound scan for the diagnosis of viable intratranquil pregnancy, inform the woman that diagnosis of the miscarriage using one ultrasound scan cannot be guaranteed to be 100% accurate, and there is a small chance that diagnosis can be incorrect, particularly at very early gestation ages. While performing an ultrasound scan to determine the viability of an intratranquil pregnancy, first look to identify fetal heartbeat. If there is no visible fetal heartbeat but there is fetal pole, measure chronogram plan. Only measure the mean gestation sac diameter if the fetal pole is not visible. If the crown of length is less than 7 mm with a transvaginal ultrasound scan and there is no visible fetal heartbeat, perform a second scan and a minimum of 7 days after the first before making a diagnosis. But the scans may be needed before the diagnosis is made. If the crown length of 7 mm or more with a transvaginal scan, there is no visible fetal heart rate beat. Seek a second opinion on the viability of the pregnancy and perform a second scan a minimum of 7 days after the first before making a diagnosis. If no visible heartbeat when the crown length is measured using the transabdominal scan, record the size of the crown length and perform a second scan a minimum of 14 days after the first before making a diagnosis. If the mean gestation sac diameter is less than 25 mm with a transvaginal ultrasound scan and there is no visible fetal pole, perform a second scan and a minimum of 7 days after the first before making diagnosis. Further scan may be needed before diagnosis can be made. If the gestation sac diameter is 25 mm or more, using the transvaginal ultrasound scan and there is no visible fetal pole, seek a second opinion on the viability of the pregnancy and or perform a second scan and a minimum of 7 days after the first before making a diagnosis. If there is no visible fetal pole and the mean gestation sac diameter is measured using transabdominal scan, record the size of the mean gestation age diameter and perform a second scan and minimum 14 days after the first before making a diagnosis. Do not use gestational age from the last menstrual period alone to determine whether the fetal heartbeat should be visible. Inform women that the date of the last menstrual period may not give an accurate representation of the gestation age because of the variability in the menstrual cycle. Inform the woman what to expect while waiting for the repeat scan, and waiting for the repeat scan has no detrimental effect on the outcome of pregnancy. And give women a 24 hours contact phone number so that they can speak to someone with experience of caring for the woman with early pregnancy complication who can understand their needs and can advise on appropriate care. When diagnosing complete miscarriage, an ultrasound scan in the presence of the previous scan In the presence of the previous scan, indicate confirming an intrauterine pregnancy, always be aware that the possibility of the pregnancy of unknown location. Advise these women to return for follow-up, for example, HCG ultrasound scan, until a definitive diagnosis is obtained. Now, using ultrasound scan for the diagnosis of the tubal ectopic pregnancy. When carrying out transvaginal ultrasound scan in the early pregnancy, look for these signs indicating that there is a tubal ectopic pregnancy and an exhale mass moving separate to the ovary comprising a gestation sac containing the yolk sac, or an exhale mass moving separately to the ovary comprising a gestation sac and a fetal pole with or without the fetal heartbeat. When carrying out the transvaginal ultrasound scan in the early pregnancy, look for these signs indicating the high probability of the tubal ectopic pregnancy. An exhale mass moving separate to the ovary with an empty gestation sac, sometimes described as the tubal ring or the Begel sign, or a complex inhomogeneous and exhale mass moving separate to the ovary. If these features are present, take into account the other intrauterine and exhale features on the scan, the woman's clinical presentation, and serum HCG before making a diagnosis. While carrying out the transvaginal ultrasound in early pregnancy, look for these signs of ectopic pregnancy. Empty uterus or collection of the fluid within the uterine cavity, sometimes described as pseudosac. If these features are present, take into account the intrauterine and exhale features on the scan and the woman's clinical presentation and HCG levels before making the diagnosis. When carrying out the transabdominal or transvaginal ultrasound scan in the early pregnancy, look for the moderate to large amount of the free fluid in the peritoneal cavity or the pouch of the Douglas, which might represent hemoperiton. If this is present, take into account the other intrauterine and exhale features on the scan, the woman's clinical presentation and HCG before making a diagnosis. When carrying out transabdominal or transvaginal scan during the early pregnancy, scan the uterus and adnexus to see if there is heterotropic pregnancy. All the ultrasound scans should be performed or directly supervised and reviewed by appropriately qualified healthcare professionals with the training in and experience of diagnosis of ectopic pregnancy. Now, HCG. Be aware that the woman with a pregnancy of unknown location should have ectopic pregnancy until location is determined. Do not use serum HCG measurement to determine the location of pregnancy. In a woman with a pregnancy of unknown location, place more importance on the clinical symptoms than on the serum HCG and review the woman's condition. Symptoms change regardless of the previous results and assessments. Use serum HCG measurements only for assessing trophoblastic proliferation to help to determine the subsequent management. Take 2 serum HCG measurements as near as possible to 48 hours apart, but no earlier, to determine the subsequent management of the pregnancy. If unknown location, take further management only after review by the senior healthcare professional. Regardless of the serum HCG measurements, give women with a pregnancy of unknown location the information about what to do if they experience any new or worsening symptoms, including the detail about how to access emergency care 24 hours a day, and advise the woman to return if there are new symptoms or existing symptoms worsen. For women with increasing in serum HCG level greater than 63% after 48 hours, inform her that she is likely to have developing intrauterine pregnancy, although the probability of ectopic pregnancy cannot be excluded, and offer an transvaginal ultrasound scan to determine the location of pregnancy between 7 to 14 days. Consider an early gestation sac for the woman with serum HCG of greater than or equal to 1500 international units per liter. If a viable pregnancy is confirmed, offer her routine antenatal care, and if a viable pregnancy is not confirmed, then refer her for immediate clinical review by the senior gynecologist. And for women with an increase in serum HCG greater than 50% after 48 hours, inform that the pregnancy is unlikely to continue if this is not confirmed, and provide with the oral or written information about where she can access supports and counseling services. Ask her to take urine pregnancy test 14 days after the second beta HCG and explain that if the test is negative, no further action is required, and if the test is positive, she should return to the early pregnancy assessment service for the clinical review within the 24 hours. And for the woman with a decrease in serum beta CT level less than 50% or increase in 63% refers for the clinical review in early pregnancy assessment services within 24 hours. If the one pregnancy of unknown location using the serial serum HCG measurements, do not use serum progesterone measurement as an adjunct to the diagnosis, either viable intrauterine or ectopic pregnancy. Now, management of the miscarriage, threatened miscarriage. Advise the woman that the viable bleeding with a vaginal bleeding and confirm intrauterine pregnancy with a fetal heartbeat, that if her bleeding gets worse or persistent beyond 14 days, she should return for the further assessment. If the bleeding smarts, she should start or continue routine antenatal care. Expecting management. Use expecting management for 7 to 14 days as an first line management strategy for the woman with a confirmed diagnosis of the miscarriage, and explore the management option other than expecting management if the woman is an increased risk of miscarriage of the hemorrhage. For example, if she is late first trimester or she has the previous adverse or traumatic experience associated with the pregnancy, for example stillbirth, miscarriage or antepartum hemorrhage, and she is at increased risk from the effect of the hemorrhage. For example, if she has coagulopathy or is unstable to have blood transfusion, or there is evidence of infection, and offer the medical management to the woman with a confirmed diagnosis of miscarriage if expecting management is not acceptable to the woman. Explain what expecting management involves, and most women will need no further treatment. Also provide women with a written and the oral and written information about the further treatment. Give all the women who undergo expecting management miscarriage oral and written information about what to expect throughout the process, and advice on the pain relief and where and when to get help in emergency. If resolution of the bleeding and pain indicates that the miscarriage has completed during 7 to 14 days of the expected management, advise the woman to take intrauterine urine pregnancy test 3 weeks and return for the individual care if it is positive. Offer a repeat scan if after a period of expecting management bleeding and pain have not started, and suggesting that the process of miscarriage has not begun or are persisting and are increasing, suggesting incomplete miscarriage, and discuss all the treatment options. Review the condition of women who opt for the continued expectant management at the minimum 14 days after follow-up appointment. Medical management. Do not offer misoprostol as a treatment for the missed or incomplete miscarriage. Offer vaginal misoprostol for the medical treatment of the missed or incomplete miscarriage, and oral administration is an unacceptable alternative if this is the woman's preference. For a woman with a missed miscarriage, use single dose of 800 microgram of misoprostol. Advise the woman that bleeding has not started 24 hours after the treatment. She should contact with her healthcare professional to determine the ongoing individualized care. For the woman with an incomplete miscarriage, use a single dose of 600 microgram of misoprostol or 800 microgram can be used as an alternative to allow alignment of the treatment protocol for both missed and incomplete miscarriage. Offer all women receiving medical management of miscarriage pain relief and antiemetics as needed. Inform the woman undergoing medical management miscarriage about what to expect throughout the process, including the length and the extent of the bleeding and the potential side effect of the treatment, including the pain, diarrhea, and vomiting. Advise the woman to take a urine pregnancy test 3 weeks after the medical management of the miscarriage, unless they experience worsening symptoms. In case, advise them to return to the healthcare professional responsible for providing medical management. Advise the woman with a positive pregnancy test after 3 weeks to return for a review by healthcare professionals to ensure that there is no molar or ectopic pregnancy. Surgical management. Where clinically appropriate, offer women undergoing a miscarriage a choice of manual vacuum aspiration under local anesthetic in an outpatient or clinical setting, or surgical management in a theater under general anesthetic. Provide oral and written information to all women undergoing surgical management of the miscarriage about the treatment option available and what to expect during and after procedure. Now, management of the tubal ectopic pregnancy. Give all the women with an ectopic pregnancy oral and written information about the treatment options and what to expect during and after treatment. How they can contact the healthcare professional for the advice after treatment if needed, and who this will be, where and when to get help in emergency. Inform the women who have an ectopic pregnancy that they can self-refer to an early pregnancy assessment service in the future pregnancy if they have any early concern. Expected management. Offer expected management as an option to the women who are clinically stable and pain-free and have tubal ectopic pregnancy measuring less than 35 mm with a no visible fetal heart on the transvaginal ultrasound scan, and have serum HCG of level of 1000 international unit or less, and are able to return for follow-up. Consider expected management as an option for who are clinically stable and pain-free and have tubal ectopic pregnancy measuring less than 35 mm with no visible fetal heart rate on transvaginal ultrasound scan, and serum HCG of 1000 and below 1500 international unit per liter, and are able to return for follow-up. For a woman with the tubal ectopic pregnancy being managed, expecting the repeat HCG level on the day 2, 4, and 7 after original test, and if the HCG level drops by 15% or more from the previous levels on the day 2, 4, and 7, then the repeat weekly until a negative results of less than 20 international unit per liter is obtained. And if the HCG level do not fall by 15%, stay the same, or rise from the previous value, review the woman's clinical condition and seek senior advice to help decide further management. Advise the woman that based on the limited evidence, there seems to be no difference in following expected medical management in the rate of the ectopic pregnancies ending naturally and the risk of the tubal rupture and the need for additional treatment, but they might need to be admitted urgently if the concern deteriorates, the health status and depression or anxiety scores. And advise the women that the time taken for ectopic pregnancy to resolve and the future fertility outcomes are likely to be the same with the expected on medical management. Medical and surgical management. Offer systemic methotrexate for the women who have no significant pain and who have unruptured tubal ectopic pregnancy with the adnexal masses of less than 35 mm, with the no visible fetal heart rate, beat and HCG, serum HCG of less than 1500 international unit per liter, and do not have intern pregnancy as confirmed on ultrasound scan, and are able to return for follow-up. Methotrexate should only be offered on the first visit when there is a definitive diagnosis of ectopic pregnancy and viable intrauterine pregnancy has been excluded, and offer surgery where the treatment with the methotrexate is not acceptable to the woman. Okay, now offer surgery as a first-line treatment to the women who are unable to return for the follow-up after methotrexate and treatment, or who have any of the following symptoms: ectopic pregnancy and significant pain, ectopic pregnancy with an adnexal masses of 35 mm or larger, ectopic pregnancy with fetal heart beat visible on the ultrasound scan, ectopic pregnancy with a serum HCG of 5000 international unit per liter, and offer the choices of methotrexate or the surgical treatment to the women with ectopic pregnancy who have serum HCG of at least 1500 international unit per liter and less than 5000 international unit per liter, who are unable to return for the follow-up and who meet the following criteria: who significantly and rupture pregnancy with index smaller than 35 mm with a no visible heartbeat and no intrauterine pregnancy. Advise the woman who chooses methotrexate that their chance of needing further intervention is increased, and they may need to be urgently admitted if the condition deteriorates. And for women with ectopic pregnancy who have had methotrexate, take serum HCG measurement in the first week, day to 4 to 7, and after treatment, and then serum HCG measurement per week until the negative result is obtained. If the serum HCG level plateau or rises, raises the woman's condition for further treatment. Now, when to perform laparoscopy? When surgical treatment is indicated for the woman with ectopic pregnancy, it should be performed laparoscopically whenever possible, taking into account the condition of the woman and complexity of the surgical procedure. Surgeon providing care to the woman with ectopic pregnancy should be competent to perform the laparoscopic surgery, and commissioners and managers should ensure that the equipment for the laparoscopic surgery is available. Now, salpingectomy and salpingotomy. Offer salpingectomy to the woman undergoing surgery for ectopic pregnancy unless they have other risk factor for infertility. Consider salpingotomy as an alternative to salpingectomy for the woman with the risk factors for infertility, such as contralateral tubal damage. Inform the women who have salpingotomy. Up to 1 in 5 women may need further treatment. The treatment may include methotrexate and or salpingectomy. For a woman who have had a salpingotomy, takes 1 serum HCG measurement at 7 days after surgery and then 1 serum HCG measurement per week until a negative result is obtained. Advise the women who have had a salpingectomy that they should take the urine pregnancy test after 3 weeks. Advise the woman to return for further assessment if the test is positive. Anti-D rhesus prophylaxis. Offer anti-D prophylaxis at a dose of 250 international unit, 50 microgram to all the rhesus negative who have a surgical procedure to manage an ectopic pregnancy or an miscarriage. Do not offer anti-D rhesus prophylaxis to the woman who receive solely medical management for ectopic pregnancy or miscarriage, or have threatened miscarriage, or have complete miscarriage, or have a pregnancy under obligation. Do not use a clear hardness for quantifying fetal maternal hemorrhage.